examination is a Osce examination. And I happen to know that after the COVID infection, the exam has been conducted in a different setup. Previously, the Osce was done in different stations. There were different stations which included writing sessions, observer stations, which may include a counseling station, history taking, to do task and all. But now, after this COVID, they are putting 20 questions with the 10 questions and 20 questions with a break in between to write. And so you will be getting 20 questions to answer. And that will be shown in the PowerPoint. And after the 10 questions, you will get a break. And again, you will be shown 10 questions. And after this 20 writing stations, you will be having a round stations. Round station means there will be patient station where you will have to examine the cranial nerves, to do counseling, to take a history, and a post-op patient with a drain, or a post-op patient, a mastoid, post-mastoid explanation, a stapedectomy patient. So with related to that case, you will be asked the questions and you have to answer accordingly. There will be an examiner to examine you and give you marks accordingly. Of course, there is a case discussion also. So now I am concentrating only to the Osce discussion part and how the Osce is being conducted now. Now I think everybody is aware about the system of conducting the examination in the present era. Can I proceed now with the questions? Hello?
Yes, madam.
Okay. So every DNP Osce, there are some common questions. That is like osteology, certain instruments, a video session showing a procedure, a radiology, you will be shown a CT scan, and then you have to identify the pathology and you have to answer accordingly. So you should be aware about these things. So in this present Osce, our first question was on the base of the skull. So base of the skull, certain foramina and structures were marked, and you were told to identify the structures A to D. So I think you all have, this is a very simple thing because you all should know about the various structures in both the extracranial component of the skull base and also the intracranial component of the skull base. Okay, so the answers were A was styloid process, B was mastoid process, C foramen magnum, and foramen ovale. So these all people should answer because this is one of the simplest questions, and you should be able to answer all these questions because this is one of the easiest ones. Some stations will be very very standard questions. Some will be very easy, and some questions will be mixed type. So you should not lose mark in all these simple areas. So you should know complete about the osteology. Okay. And the second question was the structures attached to that process was the styloid process, and ligament, and what are the structures passing the foramen magnum, and what are the structures passing through the foramen ovale. So this was the first question. I think most of you could answer this question nicely. Can we move on to the second question? Can we move the slide?
And even the styloid process itself alone can be asked as a single Osce because there are a lot of things in relation to that, like Eagle syndrome, length, development.
And there is bouquet of Riole. That question is simply what is bouquet of Riole and what are the structures attached to the styloid process? What is the importance of styloid process in parapharyngeal space. So vocabulary is usually asked as a short note and also in Osce or DMB. So shall we move on to the second case, second station question?
Yes, madam. Yes, please.
So in a OSCE, you can expect a question from PTA, you can get a question from BARA, OAE, and you should know how to do a normal PTA. Previously, when the pre-COVID time, PTA, to do PTA was a station. So now that station is not there in the present situation. You can expect a question and you will get a PTA, and based on the PTA and the various audiometric charts, you can get a question. Here, the PTA and the speech audiometry of an 8-year-old child presented with a suspected hearing loss and poor scholastic performance was given to you. And you were asked what is the most probable diagnosis. Name 4 causes for the same, and what will be the autoacoustic emission and BARA finding, and what is the etiological classification. Salima madam?
Yes. Yes, Divya.
Madam,
Yes. When you get an audiogram, first thing you should that everyone knows that you've differentiated between conductive sensory, and you can get different patterns of audiogram also, like sky slope audiogram, cookie bite. The normal clear-cut audiograms usually won't be kept for the DNB OST. And the moment you see this question, the first thing that comes to your mind is a small boy with poor scholastic performance and hearing loss. The first thing is a otitis media with effusion. So you look into that audiogram and you are seeing that it is a sensory neural hearing loss. And when you see the sensory neural hearing loss, you should always correlate it with the speech audiometry. Because in this, the audiogram appears normal, then there should be a clue. That is the speech discrimination score they have written. It is very low speech discrimination. It is only 40% and 30%, which means that it is probably auditory neuropathy. Because the hearing is, the pure tone audiogram is normal, but the speech discrimination is poor, which means that it is auditory neuropathy. So the next question was, what was the next? Name 4 causes for the same. The causes will be shared to you. Like in there is an etiological classification in which differentiates into congenital, genetic causes and acquired causes. Genetic can be syndromal nonce. In that classification, everything is there in the Scott Brown. You go through that because it takes a lot of time to discuss each and every point, so that everything is given in as tables in your Scott Brown. You can refer that. Then criteria for diagnosis of auditory neuropathy. There should be normal autoacoustic emissions and normal cochlear microphonics, and there is abnormal BARA and abnormal absent middle ear reflexes on the opposite side. That is the criteria. And along with that, other questions that may be asked is the connection gene 2630. There are different types of deafness, right? DFN-A, DFN-B, DFN-X, like that. And the genes related to that, that is proteins related to that connection 2630. All this may be asked as sub-questions. And anything else? Any other question left?
Divya madam?
Madam has given a complete description about how to approach a PTA chart. And most of the time, this PTA will be a pathological PTA, which has some pathology that will be shown to you. And you should be aware of the normal scenarios and the and also regarding the associated audiological findings of each condition. So then only you answer the sub-questions. Okay. So, madam, shall we go to the third question?
Yes, Divyesh, we can.
Yes. So, can you please move the slide, station 3? That was an instrument to identify. So you were told to identify the instrument and where this instrument is used, and you all know it's a Trifon perforator, and this is used for cochlear implant surgery. And you should know each and everything, every aspect of the cochlear implantation and the different instruments very specifically used for the cochlear implantation surgery. Venu sir, any add-on information you want to give with regard to the cochlear implantation, sir? Any other instruments to be discussed with regard to cochlear implantation? Or Shelly Salima, madam, other than this Trifon
Divya,
any other specific?
can you hear me? Can you hear
I
me?
can hear you. Sure.
So usually
Yes,
they
sir.
will keep implant also. Some days they will keep implant. Then they will ask everything about the implant. That is idea usually regarding cochlear implant.
Yeah, so different implants are now available, that double electrode. So every update of the cochlear implantation should be known by you. So you have to read the updates and the recent advances in the cochlear implantation program system, and also regarding the various cochlear implants and what are the advantages of the recent cochlear implants. So that you have to know, and the various different techniques now, any changes in the approach for putting the implant. So this is this is used for the cochlear implant surgery, VRIA technique. And the absolute contraindication for this surgery is the absence of cochlear nerve and cochlear agenesis. In these two situations, you cannot go for cochlear implantation surgery. And that the fourth question was pretty a simple question. What was the boundary? What are the boundaries of facial recess? So you all know what is facial recess and what are the boundaries of facial recess, which is medially by the vertical part of facial nerve, laterally tympanic annulus, and superior fossa impetus. And also the reason some questions are the different types of sinus tympani. What are the different what are the new classification for the different sinus tympani? What are the advantages of A, B, and C? So these microscopic, endoscopic anatomy of the middle.
Recording in progress.
And you should know, the endoscopic landmarks for the endoscopic middle ear surgery. Salima madam, please give some contribution with regard to this aspect, madam, because I am now away from ear surgery and I am just reading the updates and all. Please, madam.
Also,
Please share your thoughts.
Also, there are other approaches for cochlear implantation other than this cortical mastoidectomy, posterior tympanectomy. One is VRIA technique. And apart from that, you have a suprameatal approach, transmastoid labyrinthotomy, middle fossa approach. You should know the alternate approaches also, because the classification of inner ear malformations, there are different, that should be thorough, Senerlo-Gulu classification, and the labyrinthitis ossificans classification, that is Balcony's classification. All these classification systems you should know, and in each and every one of the inner ear malformations, there is difference in the electrodes used and the approach. Like if it is a common cavity, you use the labyrinthotomy approach, transmastoid labyrinthotomy approach. Then if it is, if you are suspecting a gusher, you should use electrodes with stoppers, like that. And if it is a small cochlea, you should use short electrodes. These are all modifications that has to be done with each inner ear malformation, and you should be thorough with the IP2, where you get enlarged LVAS, large vestibular aqueduct syndrome, where you expect a perilymph gusher also. Then about the hybrid implants also, electroacoustic stimulation, where you use shorter implants to cover that is used in the sky slope type of audiogram, where you cover the high frequencies with this cochlear implant, and the lower frequencies are covered with a hearing aid. That is hybrid type of implants. And these are and an alternative for use of this Triphon perforator for bone drilling is a newer approach is a piezotome. Piezoelectric energy can be used. Piezotome can also be used for bone drilling works in cochlear implantation. I think that just seems big. Hello.
Will we move on, madam?
Yeah.
We can move on to the next.
Yeah, we can move on to station 4. Station 4 question, it was a syndromic approach. A 41-year-old patient, recurrent epistaxis. So you should expect these sort of questions where you will be shown different pictures of a syndrome, and you have to identify the syndrome, and almost all the time you should know the pattern of inheritance also, and what is the basic genetic abnormality you see in these syndromes. So I think you could all answer this question, which is what is the diagnosis of this thing, multiple history of recurrent epistaxis with the lip showing multiple telangiectatic lesion and tongue showing lesions like this. And this is a classical case of hereditary hemorrhagic telangiectasia, Osler-Weber-Rendos syndrome. Can we go to the answer slide? And there is this peculiar criteria for the diagnosis of the for the Osler-Weber syndrome, that's hereditary hemorrhagic telangiectasia. That is called the Kurokawa criteria, and the criteria includes epistaxis, that is spontaneous recurrent nosebleed, telangiectatic lesions in lips, that is mucosal lesions, mucosal telangiectatic lesions in lips, oral cavity, nose, and also in the tips of fingers. And AV malformations you can get in cerebral, spinal, pulmonary, hepatic, and gastrointestinal telangiectatic lesions. And there will be family history, first degree relative with the hemorrhagic according to the criteria. Definite hereditary hemorrhagic telangiectasia is there if 3 criteria are present. Possible if 2 are present, and unlikely if it is fewer than 2 criteria. And this is a disease which has got transmitted via the autosomal dominant pattern, and the genes associated. 2 genes associated, yeah, there are some major genetic abnormalities which include ENG, ACVRL. You go through all these genetic mutations of the commonest syndromes we get in the ENG areas, like Pendred syndrome, anymore that is Peary-Robinson syndrome. These all syndromes, you should know what are the abnormality and what are the components of this syndrome. Salima madam, anything to be added in these of syndrome cases? They should know about the inheritance pattern, the components of syndrome, the genetic abnormality, and is there any criteria to specify for the diagnosis of this thing? This is what they you need to know about the syndrome cases. No, anything to be added, madam?
Other name is also told, no? Osler-Rendu-Weber. Yes, that's all.
So we should know the different components. These are pretty easy questions. You should know about that, especially the inheritance pattern. So shall we go to the 5th station? This was a 22-year-old female patient presented with fever, throat pain, myalgia, and abdominal pain. Total count is 8,100, and the crux is there is lymphocytosis. Lymphocytosis is 65. So when you are given a clinical scenario, just to go through the results very carefully and the history also. So here, patient presented with fever, throat pain, and there is generalized symptoms like myalgia and abdominal pain. So here, total count is 8,100. A mild leukocytosis is there with a related lymphocytosis with AST and ALT being elevated, 121 and 140. So what is your diagnosis? And if I have been given a peripheral smear picture also showing the classical downy bodies. So this is a case of downy cell. That is the classical finding in infectious mononucleosis. The organism is the Epstein-Barr virus. And that is one of the DD for a membranous tonsillar lesions. And there is a criteria for diagnosis of infectious mononucleosis, that is Hoagland's criteria, which includes a classical triad of fever, rarely more than 104, pharyngitis, which is often exudative pharyngitis, and there will be significant lymphadenopathy, and most commonly this lymph node enlargement will be in the posterior cervical group. And as in the same scenario, there will be lymphocytosis, 50%, more than 50, so more than the 50%, more than 50% will be lymphocytes, and there will be atypical lymphocytes, and that lymphocyte is called downy cell. And as in the picture, you can see there is edema in the upper eyelid that is called as a Hoagland's sign. So these different presentations in ENT, systemic diseases presenting with ENT manifestation, you should know, like vaginal granulomatosis, infectious mononucleosis, Wood-Pasteur syndrome. These all, then this one, cystic fibrosis. So these all can present with so many ENT manifestations, which you have to know what are the pathology, what is the pathogenesis for this ENT manifestation, and how will you manage the ENT manifestation along with the systemic management. There, you are not supposed to approach the patient in a tubular way. You have to approach systemically as a whole patient. So we have to look into the other symptomatology also, not the ENT alone. So that question, so in such type of question, you should know how you manage the patient as a whole. So you should know about that also when you are getting a ENT manifestation of a systemic disease. Venu sir, Salima madam, anything to be added, you please.
So, Divya, this we explained everything, but similar picture on the tones with the bacteria, gram stain may be kept. Foreign bacterial diphtheria. That's
Yes,
can
sir.
mimic. So that also they can ask. Then that immunization about diphtheria, everything they will ask. So they should read everything.
Yes, sir. You should know all the DDs of a membranous tonsillitis, and you should know even diphtheria. During the time of diphtheria, each and every aspect of diphtheria was asked in the DNB Osce when there was a surge in the diphtheria cases. Okay, so shall we move to the next station? Station 6.
Yes.
Station 3. So a 15-year-old male patient, the points here are is a 15-year-old, it's a male gender, presented with a history of progressive hoarseness and breathing difficulty. But an endoscopic picture is shown. The classical, what is the classical finding here is there are some papillomatous lesions in the membranous part of the vocal cord. And why the male patient and 15-year-old boy? Is there any importance for that? What is the diagnosis? In this case, the diagnosis is recurrent respiratory papillomatosis. And when you look into the epidemiological details of the recurrent respiratory papillomatosis, firstborn, vaginally born, firstborn male patients are, male babies are more prone for recurrent respiratory papillomatosis. Madam, it was given in the old coming. So firstborn, vaginally born male baby.
That is called Kashima's triad, no? Kashima's triad.
Yes, yes.
Vaginal delivery,
so-
firstborn and age less than 20 years.
Yeah. So this is a papillomavirus. This is caused by a viral infection. And the most common viral infection, virus responsible for this is the human papillomavirus 6 and 11. So when you are asked this question and you are, I'm sorry, the slide is moved further. Can you please go to station 6? The question was, what is the cause of this particular condition? And this is mainly by the human papillomavirus. Please don't write by human papillomavirus. You have to very specifically tell what is the type of human papillomavirus responsible for this recurrent papillomatosis. And this is mainly by 6 and 11. 6 and 11 human papillomavirus is commonly associated with benign conditions. And in the present era, it is a HPV positive oropharyngeal carcinoma and all. It is 16 and 18. You should know what are the types responsible for the benign lesions and what are the types which are responsible for the malignant lesions. So when you are asked for recurrent respiratory papillomavirus, what is the organism, you have to write 6 and 11 human papillomavirus. That is the main virus which is responsible for this. And the treatment of this respiratory papillomavirus, so there are so many studies going on with regard to this particular disease. The concept of treatment was previously it was cold steel. Now people are telling that when you can use laser, you can use microdebrider. Microdebrider is to debulk. Sometimes it will be so bulky disease and it may be compromising the airway. So with the microdebrider, just like in polyp, we use in nasal polyposis, we can use the laryngeal microdebrider to debulk the bulkiness of the lesion and it can create an airway. So some study shows that as far as possible, try to avoid tracheostomy in recurrent respiratory papillomatosis because that will also pave the way for the formation of papillomatosis around the stoma. Then it will be very difficult to manage. So these are the reasons. So recent advances are microdebrider and using laser to completely excise the disease. And some people say that after the excision, you can even use topical mitomycin to prevent scarring and granulations. And that's to granulation. And also you can use intralesional antiviral drug can be put in the bed of the lesion. So that will also decrease the chance of recurrence. So when you are asked about the treatment should, one is excision, and what is the treatment given excision. There are so many papers telling that intralesional post-excision, intralesional pseudophore injection, there is a better result and giving less recurrence. And other adjuvant therapy. So you always have to tell the main treatment along with the adjuvant therapies. So adjuvant therapies are the pseudophore, interferon alpha, indole 3 carbinol. Indole 3 carbinol is extracted from cabbage. These are all adjuvant therapies that will prevent the recurrence of respiratory papillomatosis, where recurrence is a notorious problem which we face. Anything to be added in this particular case?
Also indications for the adjuvant therapy.
Madam?
Indications for the adjuvant therapy, like requiring more than 4 procedures per year, distal multiple site involvement, rapid regrowth. These are the main indications for adjuvant therapy. Also, the role of bevacizumab is also there, no, for intralesional injection, which inhibits the VEGF.
We are always putting this intralesional after the excision, madam, they are doing it to prevent recurrence. Where I see 2-3 papers where pseudophore is doing fine in this particular situation. Am I right, madam? Pseudophore has got a good role in preventing recurrence, no?
And previously, the bevacizumab was also compared, no, with pseudophore. So if they are asked for two drugs used for intralesional treatment, they can write like that.
Yes.
Also, there is a vaccine, role of vaccines, no, Divya?
Yeah, and then now it is the era of HPV vaccines, and just like for cervical carcinoma, in Western countries they have implemented this one human papilloma virus vaccine. Now people are thinking this human papilloma virus vaccine can be used for control of oropharyngeal carcinoma also. So it is targeting the 16 and 18. So cervical carcinoma is also caused by 16 and 18. The same 16 is causing the oropharyngeal carcinoma. So people are thinking that we can use it for prevention of oropharyngeal carcinoma also in our ENG area. So you should know about, there are so many vaccines now. There are monovalent 9 vaccines, 9 viral types of HPV has been introduced, and it is called nanovalent HPV vaccine that has also come into market. But I don't know whether it is available in India. So you should know about various HPV vaccines, and some trials are going in Manipur. I think it's in Manipur for
I
all
think the name
pubertal
of the
girls and
vaccine
all
is
there are
Gardasil is kept as a sponsor, no? Osce, this vaccine.
the reason this nanovalent 9 vaccine is there. I don't
Right.
remember the correct vaccine. I will nine types. Actually, HP previously was 2, then 16, 18, 31, 33. Now the recent one is
It's
9
not
HPV strains are. Yeah, that is the recent one. So it will encompass all. I forgot the name. I will tell you. That is marketed by Merck.
That
I
is
think.
Gardasil.
Merck. Yeah,
So I think one
let
is
you
kept as an Osce also, Gardasil. Like for a drug.
Nonavalent HPV vaccine. There was bivalent, quadrivalent, now is the nonavalent. I will tell you the name later, but I forgot actually. Anything more Gardasil. Madam, that is Gardasil.
Gardasil.
Can we go to the next question? So, in many of these OCs, you will be given a drug, and you will be asked about what is the mechanism of action, what are the important side effects. And with regard to the drug, you may be asked the condition where it is used, and questions will be asked with related to the condition also. And they will deviate from the drug and they will go to the condition. Just like here, what is the dosage and mechanism of carbimazole? That is neomercazole. What is the action of neomercazole? So you should know the normal dosage, that is 20 to 60 milligram per day, and children it is less dose, that is 15 milligram. It is what exactly this neomercazole do is it prevents the binding of iodine to tyrosine. The iodination of the tyrosine residue is prevented by this one, and that will that is happening because of the inhibition of the peroxidase enzymes. So you should know the dosage and what are the. What was the second question? Can you just go? And then can you go to the previous slide? Yeah.
Normal values of TSH.
FT3, FT4, and TSH. And that you should know. Then what is acropachy means thyroid acropachy. And what are the other drugs used along with this anti-thyroid drugs to prevent the
management of thyroid.
when you give a beta blocker along with an anti-thyroid drug, that you should also know that when there is significant tachycardia and the patient is having going for atrial fibrillation, when the patient is having a coexisting cardiac problem also, you have to give drugs. Then how will you prepare a patient with thyrotoxicosis? A patient with a thyrotoxis, how will you prepare the patient for thyroidectomy? How will you control the hyperthyroidism? And what are the anticipated problems during the thyroid surgery? And how will you prevent thyroid storm? So any patient with hyperthyroidism should be optimized, should be controlled, the thyroid function level should be maintained before taking the patient for thyroidectomy. And this is mainly to avoid the complication that is the thyroid storm. Suppose if the patient is having, even if we have optimized, some patients are more prone for developing thyroid storm, some fluctuating thyroid function. Some patients can have, once you stop the thyroid, once you stop thyroid, anti-thyroid drugs, then they will go for hyperthyroidism. When we decrease that, when you increase the dose, they will go for extreme hypothyroidism. So in the clinical scenario, we will see these sort of patients. These sort of patients are unpredictable, and these patients are more prone to develop thyroid storm. So in such a situation, how will you manage thyroid storm? So with the beta blockers, and how will you prepare the patient? And steroids have got an important role. Madam, anything to be addressed other than this thyroid storm in this particular situation?
In thyroid storm or other than thyroid storm, you mean?
Other than thyroid storm, how will
Other
these
than
are the questions
thyroid
usually
storm,
they ask.
actually, they can be asked about thyrotoxicosis, eye features, eye signs. All this can be asked. No?
And so regarding this preparing the patient with the thyrotoxicosis, that is also very important. Previously, we used to give glucosidin and all. That historically important procedures they will also ask. Madam, previously glucosidin was given to prepare the patients for thyrotoxicosis. Nowadays, whenever nobody else do this glucosidin management to prepare the patient, most of the time these patients will be managed by anti-thyroid drugs. That is what I have seen. And anything to be discussed about glucosidin and all?
I don't think so. Just mention that glucosidin can also be used in thyrotoxicosis.
That historically we go for that. Then some other measures, treat the measures like cardiac symptoms, fever and hypotension. Then the 15th question was about the management. What is Dunhill's operation? A Dunhill's operation is removing one part of the thyroid, and you are also addressing the contralateral lobe. Removing almost a part of the opposite lobe, except a small amount of thyroid near the tracheoesophageal groove. That previously it was called subtotal, or 1 gram of the thyroid tissue is retained to prevent the tracheoesophageal groove, to prevent injury to the retrolaryngeum and also to preserve the parathyroid. But nowadays, it's only a historically important operation. Nowadays, it is never done. Now, when you are asked about thyroidectomy, now people are either doing lobectomy or total thyroidectomy. The old concept of subtotal thyroidectomy, near total thyroidectomy are not usually done nowadays. So these are all previous historically important Dunhill operation. Now, when you do thyroidectomy, either lobectomy or total thyroidectomy. That is the classical operations now we do. But we have to know about the previous operation, what is subtotal. This is also here what Dunhill's operation is. You are keeping a small part of thyroid tissue in the contralateral side near the tracheoesophageal groove. So in this picture, you can see what all part is removed and what all part is retained, and where exactly is the thyroid tissue is retained. And sometimes you may ask about what is central compartment, what is the extent of central compartment. So central compartment now includes both level 6 and level 7 diffuse. The anatomical boundaries of central compartment from the inferior quarter of thyroid to the innominative vein. So, what is central compartment? You have to tell both level 6 and level 7. Level 6 is from thyroid bone to the suprasternal notch. Level 7 is situated between the suprasternal notch and the innominate vein, laterally by the carotid sheath. So central compartment now it is included is level 6 and level 7 nodes. These are the usual questions which is being asked along with thyroid at your level. And which are lymph nodes are included in level 6 is pre-laryngeal, pre-tracheal, right paratracheal, and the left paratracheal lymph nodes. And what are the different types of tracheal invasion in thyroid malignancy? What are the different types of tracheal infections? Classification. You have to, there are 4 types of classification. These are all the usual questions with regard to thyroid they ask, because the tracheal invasion by the thyroid malignancy, we should know how to manage and all. I think this is enough for thyroid. I think complications. What are the incidents of permanent? What are the incidents of temporary adrenalinopathy? What are the incidents of permanent hypoparathyroidism? What are the incidents of temporary hypoparathyroidism? And the recent advances in thyroidectomy is the electronic nerve monitoring. The nerve monitoring can be immediate nerve monitoring and continuous nerve monitoring. And for both lateral nerve and external laryngeal nerve.
Recording in progress.
Indigo cyan green, autofluorescence and indigo cyan green for the identifications and preservation of parathyroid. These are the 2 recent advances in the thyroidectomy field. One is the nerve monitoring, second one is the autofluorescence and indigo cyan green.
Yes, madam, you're audible. You're audible. Yes, madam.
Really, I lost the screen. That's right.
No, now you're audible.
And indigo cyan green. In autofluorescence is to identify the parathyroid. And after identifying the parathyroid and completing the thyroidectomy, you give indigo cyan green to the patient via intravenous route, and then you will assess the vascularity of the parathyroid you have preserved. So these are the techniques to prevent hypocalcemia in the post-operative setting. So these 2 things you just read about: nerve monitoring and autofluorescence and indigo cyan green with regard to the parathyroid. And the question was, identify the surgical procedure. That was a percutaneous tracheostomy. Name 2 methods for the procedure. These are the Seldinger technique, Ciaglia technique. There are so many other techniques like Briggs technique, translaryngeal technique, balloon dilatational technique. The indications are mainly this percutaneous tracheostomy is done in the ICU setup when the patient needs a prolonged ventilation and also for tracheobronchial toilet. The problem is if the patient is having a big thyroid in the neck, if the patient's neck is very short, if there is cervical instability, there is any bleeding coagulopathy in this patient, and of course in laryngeal malignancies and all, you can go for a percutaneous tracheostomy. And there you have to go for the conventional one. So what is jaw flap means? After the once you identify the trachea, there are different ways of opening the trachea. Either you can put an intercartilaginous incision, you can do a window technique where you remove a part of the tracheal cartilages that is mainly done in permanent tracheostomy, like in palliative setting and all, where you want to create an airway. And jaw flap is a inferiorly based a rectangular flap is taken, and that flap is stitched to the skin edge. This is usually done in a temporary tracheostomy and also in children moving to the jaw flap. So these are the various types of tracheotomies: jaw flap, window tracheotomy, intercartilaginous incision, slit tracheotomy. There are the different techniques. So you should know all the techniques of opening the trachea, the advantages and the disadvantages. Especially the jaw flap, that is mainly done in temporary tracheostomy and also in children to keep that opening patent. Madam, any points to be added in this aspect? Tracheostomy,
and the
high tracheostomy.
yes, high indications, types of tracheostomy we have to know. Also, this blue rhino, no, percutaneous dilatational tracheostomy set. Blue rhino is kept as a spot. Osce.
Okay.
And contraindications we discussed.
So, if the tracheostomy indications, what are the surgical approaches? What are the types of tracheostomy? What are the complications of tracheostomy? And the various tracheostomy tubes also you should know. And you should also know about the mediastinal tracheostomy, a word about mediastinal tracheostomy. And when will you do a mediastinal tracheostomy? It is a grandiose method. Mediastinal, just read it can be asked as a short note also, mediastinal tracheostomy. Sometimes you may be asked about mediastinal tracheostomy also. I think that is more than enough for tracheostomy, madam? It's okay, no?
Yes. And also tracheostomy care, the cuff pressure and all. Few points on tracheostomy care, then asking. HME, what is HME?
Tracheostomy care, how much is the cuff pressure and what is the pressure of the suction apparatus when you want to do a suction in the tracheostomy tube. That also is important.
Also
That
the size
too
of
you
the
have to
suction.
remember.
Size of the catheter also.
Tracheostomy, in and out of tracheostomy, the history of tracheostomy, everything can be asked. So shall we move to the next station?
Yes.
So this was a station where we were asked about the general concept, how the hospital waste is being discarded. And this is very important. In most of the OSCE, this is asked, and you should know where this each materials like glass pieces, sharp materials, plastic, contaminated materials, cytotoxic drugs, blood and body fluid. These all has got a peculiar color code. And
And also you should know the color coding of the various things that is given in the picture. But there is one modification, that is if you are given the black color, the cytotoxic drugs has to be put in the black. But some papers it is written that it is to be disposed of in the yellow. So depend, if the black is given, you can write cytotoxic drugs inside the black one. Also in this picture, the gloves are written in the blue, but it is actually in the red. The other things you can follow what is given in the picture. So you should know what is bio-waste management properly and how each of these bags that is given in the bottom of that picture, how they are disposed of. That is just a theoretical question. You can refer to that.
Hello, am I audible? I lost the net in between. Am I audible?
Yes, Divya, now you are audible. And this
I don't know sometimes.
This we discussed.
Is it?
This thing is discussed, Divya.
Okay.
Actually, it is a theoretical, no?
Regarding the waste management, I didn't go through that one. Actually, I'm not seeing the screen also. I don't know, in this place, sometimes the net maybe. I'm not seeing the screen. Now, which case we are discussing, madam?
The bio-waste itself, the answers we are discussing.
Okay, I'm not getting this screen.
So you can log.
Now I can see, madam. Okay.
Now you can.
Yes, madam, I can see. I can see. Okay. So we have discussed the bio-waste material management, no? And we will go to the next 10th question. So this is often asked how to write an article, under which headings you will write an article, and what are the citing references, how will you quote the references, what is the most common style or the system which we follow for quoting the references, and what is Prisma. That Prisma is mainly for systematic review and meta-analysis. And what you have to know about writing an article, this you have to know because this is an indirect way to assess whether you are writing articles or not. So any article, it will start with an abstract, the introduction, the methodology, that means the materials and methods, results, discussion, conclusion, and references. And there are two systems of references, that is quoting the references, that is the Vancouver style. And many of the journals, they prefer Vancouver style, and you should know how to write the Vancouver system, because since we have all done your thesis work, you will be knowing the Vancouver system of quoting the references. And the fourth one was, what is Prisma? Prisma is preferred reporting items for systematic reviews and meta-analysis. Systematic review and meta-analysis, you are collecting certain articles based on your key. So you want to review, you want to know what is the prognosis of early tongue carcinomas. You collect all the early tongue carcinoma related articles and the prognosis, and then you review, and then you analyze what is the data. So that has got a good evidence in the present scenario. So it is an evidence-based minimum set of items for writing in systematic reviews and meta-analysis, and the stronger strengthening the reporting of observational studies in epidemiology. So in DNB OSCE, definitely a question will be there with regard to the evidence, with regards to the
recording in progress.
And sometimes you will be given a question to work out. Like sensitivity, specificity, positive predictive value, negative predictive value, incidence, prevalence, then some Forrester plot with regard to the meta-analysis will be shown, and identify the Forrester plot. What is ROC curve? So these are all statistical, basic statistics will be asked. So you should know about these. One definite question will be there from statistics. And also from evidence. What is RCT? Randomized controlled trial. What is bias? What is confounding bias? So these basics of statistics you should all know, and you have to refer to. So these are the areas where you will expect and you can get marks also. Okay.
We'll move to the next slide.
Ma'am, shall we move on to the next slide? Hello?
This was a case scenario. Again, a 13-year-old boy presented with the right-sided throat pain and fever of 5 days duration. The pain radiated to the right ear and right side of it. He later developed cough, dyspnea, and painful breathing. So what is the condition? So here the boy is 13-year-old boy. Right side throat pain and fever. So that means there is some process of infection in the throat. And that is causing infections in the organ. That's because the patient is having fever. And the pain is radiating to the right ear and neck. So when you are given a scenario, go through each and every point they are showing. So it is a case of Lemire syndrome where there is thrombophlebitis of the IJV, secondary to an infection of the tonsil or in the parapharyngeal space. And there is the infected thrombus in the IJ, and that's a type of thrombus, so infected thromboembolism. I'm sorry, my net is going in between. That is why my sound is breaking. Am I audible now? Okay now? Anurag,
Sound is
am
breaking.
I? It is breaking
Yes, madam. Yes.
now also.
Little bit. Hello?
Actually, my net is breaking in between. That is the problem.
Okay, madam. You continue, please.
I will try to get another net because I am in the 8th floor of this hospital. That is why Geo may be getting. Madam, can you please continue? I will try to get another net connection. Give me 1 minute.
Now you're okay. Now you're okay. Hello?
So about this case, everything is written on the slide. So you should read everything. The commonest organs which is mentioned, antibiotic use. Then what is Lincoln favor? They usually ask. Then search criteria. So this is only a guideline. You should read everything. Okay.
So when am I audible now?
Yes, madam. Yes.
Yeah. So in this condition, so this Lemire syndrome, Lincoln-Syme, you should know about the parapharyngeal space, the pre-styloid, post-styloid compartment, what is the extent of what are the main structures in the post-styloid compartment, how will you manage a parapharyngeal space infection, what are the complications of parapharyngeal and retropharyngeal infection. So these are all factors, and also you should know about the various cervical fascia, like the pretracheal fascia, prevertebral fascia, deep intestine, pretracheal fascia, prevertebral fascia, and what is carotid sheath. These all factors that the anatomy of the neck should be absolutely known for you. Then only you can answer these questions. And the first criteria, you can read, you go and read about the first criteria. Shall we proceed to the next
Okay.
station? So these are 3 symbols, and you are asked to identify which are the symbols. And A is what? It's a biohazard. Second one is laser surgery is going on. That symbol to show that the laser surgery is going on. And the third one is radiation. So a important question with regard to this laser is, what is airway fire? There are three components for airway fire, and laser, you should know what are the prerequisites before doing a laser surgery. What are the endotracheal tubes you use for laser surgery? What are the precautions you use while doing a laser surgery? And what will you do when you anticipate or when you come across an airway fire? So these aspects of laser surgery should be known to you. Airway fire is a very important question. And how will you approach when there is a airway fire in laser surgery? And the second question was, what are the CDC approved levels of biosafety? With an example for each, there are different biosafety level 1 to 4, and the level 1, you can go through this. The CDC classification, the latest biomicrobes are included in biological safety level 1, and the high risk, the Ebola and Marburg viruses are included in the biosafety level 4. So these are some general questions you can expect, and you have to know about that. Sometimes you may get some questions which are not at all known to you, but don't get panicked if you get a question in between. There may be some simple questions. Just if you know that answer, right. If you do not keep quiet, we will get a good question. Don't lose your heart if you get a question in between. If you don't. That's the most important thing. You have to keep it in your mind when you are approaching a DNB Osce. Some stations will be extremely difficult. Don't lose your heart there. Next station will be very much easy. So hope every time for the best. So don't lose your heart in between. Okay. So shall we go to the 13th question? This was a culture media. What was a culture media? That was a Lowenstein-Jensen medium, selective media for tuberculosis. You all should know what is the composition of this Lowenstein-Jensen medium. In the next slide, you can go through that. What are the components of Lowenstein-Jensen medium? And definitely they will ask about the recent National Tuberculosis Control Program, the various regimes, what are the definition, what is the definition for a drug-resistant tuberculosis, what is the exact difference between a multi-drug resistant tuberculosis and extended drug-resistant tuberculosis. And these all aspects, every aspect of this National Tuberculosis Control Program, even though it is not, we are not managing it, you should be aware about it. Because most of the time we will diagnose tuberculosis and we will send for treatment, but you should know what regime they are going to get and what you should know the definition of multi-drug resistant and extended. These are all given in the National Tuberculosis Control Program. That there is a protocol that is there. This is all completely given. And the last question was
I think audio is breaking. So what is NICS TB trial? It's an open label single group study for treatment of XDR tuberculosis. And that was with 3 drugs. That is bedaquiline, pritomanid, and linezolid. Bedaquiline was once asked as a Osce station. So you may be asked about XDR. Exactly what is the difference between MDR? What is RR-TB, rifampicin resistant TB, XDR TB, pre-XDR TB? All this terminology you should know. I think we can move on to the next slide. So what is the radiological finding with diagnosis. So when you are asked like this, you should say what is the finding and then give the diagnosis. So you can see that CSF is white in this. So it means that it is a T2 weighted MRI. So T2 weighted MRI, and over the sphenoid sinus, you can see some CSF is collecting and the pituitary is not fully delineated. So it is a T2 weighted MRI of showing a CSF filling the sella turcica with decrease in size of the compressed pituitary gland. So your diagnosis is empty sella syndrome. So that is the diagnosis is empty sella syndrome. It can be primary or secondary. That is the etiological classification. Can be primary or secondary. In primary, there is no cause, which means that the diaphragma sellae, which is the dural covering of the sella turcica, is weak, so that the arachnoid herniates into the sella, and with the pulsations that CSF gets collected in the sella turcica, and that compresses the pituitary gland. That is primary. And in secondary, there should be some cause, like pituitary has undergone atrophy due to many reasons, like Sheehan syndrome, that is postpartum pituitary apoplexy, then following pituitary tumor surgeries, head trauma, radiation and all. Slide, previous slide. Previous slide. Slide തന്നെ പോയി. അല്ല, okay. So answer slide. So what is the radiological classification with the criteria? Radiologically, it is classified as complete or total empty sella or a partial empty sella. It is total when more than 50% of sella is filled with CSF, and pituitary thickness of the pituitary is less than or equal to 2. It is partial empty sella when less than 50% filled with CSF with pituitary size more than or equal to 3 mm. And the next question was, what is modified Dandy's criteria? So one common association with this empty sella syndrome is benign intracranial hypertension. So modified Dandy's criteria is the criteria to diagnose benign intracranial hypertension, in which there are symptoms of, these are the criteria, that is symptoms of raised ICT. There is no localizing sign except that is false localizing sign of an abducent nerve palsy. The patient, there will be no alteration in the consciousness level of the patient. Normal CT, it is not VT, it is CT. Normal CT or MRI findings without evidence of any thrombosis, because raised intracranial tension one causes IJV thrombosis. So there is no evidence of thrombosis. And while doing LP, the opening pressure will be more than 250 with normal composition, cytological and biochemical composition of CSF, and no other explanation for raised intracranial tension. So these are the criteria for modified Dandy's criteria for diagnosing benign intracranial hypertension. And what role does it play in ENT? It is one of the causes for CSF rhinorrhea. Because if you treat a CSF rhinorrhea without correcting the intracranial hypertension, it will result in a recurrence or a persistent leak. So this, and if you correct the intracranial hypertension, the leak may stop spontaneously, either with medicines or LP shunt. You can treat it, so the CSF leak may revert spontaneously. Without correcting the intracranial hypertension, should never plan for a CSF leak surgery.
Divya madam, anything to add?
Am I audible? Now I got a new net connection. I'm sorry for that. My Geo is not working, sir. Yes. Am I audible?
Yes, very much.
Yeah. So the station 15, most of the time they will keep one histopathology slide, and you can even get a microbiology slide also. So these two slides, the first slide is the switch key pattern of adenoid cystic carcinoma, and the second one is the classical inverted papilloma. So the questions were based on the histological slide. The first question, what are the different types of adenoid cystic carcinoma? There are three types mainly, the solid one, cribriform one, and the tubular one. The commonest is the tubular one, and the most aggressive type of adenoid cystic carcinoma is the solid type of adenoid cystic carcinoma. And second question which related to the inverted papilloma was, what is the staging system? You should know the PROS staging system. It is used for staging the inverted papilloma. And whenever you are getting a question on inverted papilloma, the reason, what is the classical MRI finding inverted papilloma, you should know, and what is the reason for that particular finding. And you should also know the different types of endoscopic medial maxillectomy. These all you should go and read in the different types of endoscopic medial maxillectomy. And the third question which can be asked with regard to inverted papilloma is the Sterman-Canfield operation. That is the type 3 endoscopic medial maxillectomy. So you will be knowing type 3 medial maxillectomy, but when they ask about Sterman-Canfield operation, you will not be able to write. So these alternative names and all details regarding the inverted papilloma should be known. And the most important during the surgical approach, the most important part in the management is to drill out the hyperostotic segment where the inverted papilloma is coming out. So whenever you get an inverted papilloma, there may be a foci of hyperostosis, and that area you should have to drill after the excision of the inverted papilloma to prevent the recurrence. So these are some points with regard to the inverted papilloma. And what is the most peculiarity of the tumor adenoid cystic carcinoma? You all know it is the perineural extension of the disease. And so when you get a adenoid cystic carcinoma in the skull base, especially in the nose and paranasal sinuses, we should be very much particular in looking into the foraminers of the skull base. If there is widening of the skull bases and the tumor is adjacent to that, you should think of an extension of the disease through the nerves. So that is one criteria, where there is widening of the foramen ovale and where there is hypercontrast enhancement along the nerve. That is one another criteria to think that there is perineural extension of the disease. And one more point, in adenoid cystic, what is the most commonest translocation? There are so many in adenoid cystic carcinoma. There is a translocation between 6th and the 9th chromosome, and that was also sometimes asked. That is the commonest chromosomal translocation you come across in adenoid cystic carcinoma. And also regarding the various genetic mutations that can come across in salivary gland tumors. That not often asked, but some there are targeted c-KIT mutations and all these are there. c-KIT targeted therapy and all that. It's not frequently asked, but you should know some basic genetic basis of this adenoid cystic carcinoma, which is being used for targeted therapy. Okay. So shall we move to the next station?
This
Okay. So this question is often asked for your Osce. How will you counsel a patient? Counsel a patient. Here the question, if you read, how will you counsel a patient? Can you please go through the question? Patient planned for total laryngectomy in a 3 days period for stage 3 glottic carcinoma. So stage 3 glottic carcinoma, it can be T1N1. So it can be any patient with N plus, that is N1, it is stage 3. So most often it will be written as either as a T3 glottic carcinoma or a T4 glottic carcinoma. So the correct here is, if it is asked for a counseling in a T3 glottic carcinoma, you should be very careful, because T3 glottic carcinoma, the current treatment modality is concurrent chemoradiotherapy. So it is always a organ preservation treatment we offer for a T3 glottic carcinoma. That means a T3 disease. But when will you go for an upfront total laryngectomy in a T3 case? That is, when you are getting a dysfunctional larynx, that means a larynx which is not doing its functions like protecting the lower airway. When the patient is having severe aspiration and the patient is on a rice tube, that means the function of protecting the lower airway is not happening. Second is maintaining the airway. So that if the patient is on tracheostomy, that patient is not getting an airway passage because of the malignancy. So when these two functions are affected because of a malignancy, and if the patient is on a tracheostomy tube or a rice tube, even if there is no thyroid cartilage or a cricoid cartilage erosion, you will not go for an organ preservation protocol. That means a concurrent chemo. In T3 disease, you actually always go according to the RTOG 9111. So that is the landmark trial which suggested or give the evidence for using concurrent chemo in laryngeal carcinomas. So in a T3 larynx, if somebody is going for a concurrent chemo that is based on RTOG 9111 trial, and we always try to preserve the larynx. But in certain situations of laryngeal carcinoma where the laryngeal functions are affected, you won't go for an organ preservation protocol, you will go for an upfront surgery. So when you are asked for counseling a patient with the T3 carcinoma glottis or a supraglottis, the first question when you counsel is, why we are doing a laryngectomy for this patient, that you have to tell the patient. Because even though you are not having a cartilage eroding disease, why we are doing, because your larynx is not functioning properly and there is no point in preserving the larynx. That indication we have to tell. That is the point you have to stress upon when you are asked about a T3 larynx. Whereas in a T4 larynx, there is no problem. In all thyroid cartilage eroding disease, cartilage eroding, operable disease, you will go for a laryngectomy, upfront laryngectomy. And in both these cases, you have to give adjuvant therapy also. What are the other things you have to, why you are doing surgery? That's the first thing. What is the disease? What is the nature of the disease? Why we are going for a surgery? What is the indication of surgery here? And what are the problems this patient is going to develop after the surgery? And how you are going to, what are the permanent? That is permanent stoma, permanent loss of voice. There is lack of nasal respiration, so there will be loss of olfaction. There is decreased perception of smell, and we will not able to do any strenuous activities. These are the 4 permanent problems this patient is going to have. But how can we tackle this? Voice rehabilitation, that also you have to tell, you can take what are the rehabilitative measures you can take and what are the problems there are. You should not give the negative component. Even if you remove the larynx, we are having so many rehabilitative measures to bring back your voice. There are so many techniques. So you have to give a positive approach to the patient. Along with that, you have to tell that after the surgery, you need adjuvant therapy in the form of radiotherapy with or without chemotherapy, and also the possible complications the patient can develop in the post-operative period. So this is very important when you don't, last time when we did a Osce in Calicut Medical College, when we gave this scenario, most of the students wonder, you need a surgery. So you first tell what is the nature of the disease you have. You have to first, whenever you get a counseling station, you first introduce yourself and you tell the patient that I am here to give you counseling regarding your treatment. Then you know you have a disease like this. This has to be treated. Since your disease is in advanced stage, you need multiple treatment. And why we are opting for surgery? This is how you start the counseling. Don't upfront tell, hey, we are going to take out your voice box. First, tell what is the need of surgery here, why you want to do the surgery, and what are the advantages of doing the surgery and disadvantages. And always create a positive approach in the patient rather than giving a negative approach. So this is an important thing which I have to mention in this particular station. Because last time there were about 60 students there. Most of the students were first itself they are telling you are going to knock out your larynx. So most of the patients will not be able to hear that first. So you start with a small introduction about the nature of the disease, the need of multimodality, what are we going to get, what are the functions of larynx which you are going to lose by this, and how we will rehabilitate that. That is how a counseling station. And if you do a good counseling, that station you can score good marks also. So don't make mistakes in these particular task stations and observer stations. Sir, I think this is enough for this counseling station.
No. Madam, shall we stop then? That's all. Once the dad gets the next stop. Hello, Divya madam?
Yes, madam. Can we, are we?
No, we have time, but if you want, you
Then
can continue. One more slide is there.
you can continue, no problem.
Oh, okay.
If the time permits and the sirs are all
Time is-
willing, if
this
it is
time is
given
there.
for
This was not asked as a question. We just kept 15.
okay,
Okay.
then not even. See, all kept, we have kept for the questions which we have kept, we have discussed, no?
Yes, madam. That is all.
So,
Then it's
Dr.
okay.
Divya,
Yes, sir.
thank you very much. Anyway, we will give it a chance to other so many faculties are already ended. They will give their opinion also.
Sir, I'm so sorry. In between, I net got disconnected.
No
That's
problem.
the
This,
problem.
by the time Sarima managed it. Don't worry.
Okay, sir. Actually, here, no, the Geo in between goes, sir. So I got it from one of my students. She's helping me now.
Okay, other faculties, those who are ended the session. Dr. Sadar is there. Dr. Sadar.
Yes, madam. Yes, madam. There is a excellent discussion going on.
So you add something. I add something to it.
Things are going on well. Nothing to say further. Thank you.
Okay. Dr. Shanti. Dr. Shanti is there.
Yes.
So please add to this.
No, I think most of the things were discussed. And maybe I think we also should be reading a lot now.
Also,
more.
by
But I
conducting
feel
this,
that
we
this
will
is-
read more.
No, I think we also have to get updated in a lot of things.
Oh, okay. Thank you. Dr. Pramod. Dr. Pramod. So any other faculty? Please give your contribution.
So I think we can wind up the session. So this was to just give a general orientation about the Osce. So we have missed a lot of topics. We would like to know the opinions of the candidates. If anyone has to tell anything, please. You can do it now. Do you need more sessions? I'm asking the students.
How many exam going PGs are there this time? Anupama, you're there, no? Next time.
ഇപ്പോഴല്ല വേണം 6 months കഴിഞ്ഞിട്ട്
So any exam going PGs?
4 months കഴിഞ്ഞിട്ട് നല്ല യൂസ്ഫുൾ ആയിരുന്നു മാഡം.
Please give your suggestion whether to be continued further or Dr. Anupama,
Sir.
please give your suggestion whether to be continued for the coming
ആ
months
സാർ
or
സാർ ഒരു once in 2 months ഉണ്ടെങ്കിൽ നല്ലതായിരുന്നു.
okay.
ഞങ്ങൾക്ക് വേറെ എങ്ങൊന്നും ഇങ്ങനെ ഓസ്കി കാൽമെഡ് അല്ലാതെ കിട്ടാറില്ല. കാൽമെഡ് അല്ല വൺസ് ഇൻ എ ഇയർ കാൽമെഡ് നടത്തുന്നതല്ലാതെ ഓസ്കി വേറെ എവിടെയും മോക്ക് ഓസ്കി കണ്ടക്ട് ചെയ്യുന്നില്ല. അപ്പൊ സാർ തീർച്ചയായിട്ടും യൂസ്ഫുൾ ആണ് സാർ.
So we will try. Okay.
മാഡം എക്സ്പ്ലെയിൻ ചെയ്തതെല്ലാം വളരെ യൂസ്ഫുൾ ആയി പോയിന്റ്സ് ഒക്കെ എഴുതി എടുത്തിട്ടുണ്ട്.
She explained very well.
താങ്ക്
She
യു
is ideal.
താങ്ക് യു വെരി മച്ച് സർ.
Other students suggestions.